Okay, so welcome to everybody. Welcome to the fourth webinar of our community of practice for Lewy body dementia. Today's topic will be sleep disturbances in Lewy body dementia. So the members of our core team who are here today, myself, Angela Penny. I'm an advanced speech and language therapist in progressive and complex neurology, working at Airedale NHS Foundation Trust in Yorkshire. We also have Rachel Thompson, who is a consultant admiral nurse for Lewy body dementia, working in a national role for Dementia UK and Lewy Body Society, waving. And also Claire Johnson, who's a specialist occupational therapist in Parkinson's, working for University Hospitals of Derby and Burton NHS Foundation Trust. So today's outline, I'll be giving a brief overview of Lewy body dementia for those who are new to the community of practice and may not have joined us before. We did go into more detail in the launch event in July 2023, which is available to watch again on YouTube. And you can see a link that'll go into the chat if you weren't here in July for that, and you can watch it again. And then Rachel and Claire will take us through sleep disturbance and strategies. And we'll hopefully have time for questions after all the presentations have finished. Next slide, please. So, Lewy body dementia. To recap then, this is the second most common cause of neurodegenerative dementia, with approximately 125,000 people in the UK with Lewy body dementia. It's an umbrella term for dementia with Lewy bodies and Parkinson's disease dementia. Not everyone with Parkinson's disease will go on to develop Parkinson's dementia. It's about 30% overall. But the longer that people live with Parkinson's, the more increased risk they have of developing it. The 1-year rule is from a consensus report developed by Ian McKeith and colleagues up in Newcastle, and it helps us differentiate between the two. Next slide, please. So, Lewy bodies. This condition is associated with abnormal deposits of alpha-synuclein protein in the brain called Lewy bodies, named after Dr. Lewy, who discovered them. And these deposits can lead to problems with thinking, movement, behaviour and mood. And the crossover with Parkinson's come in with this loss of neurotransmitters, particularly the dopamine neurotransmitter. Next slide, please. Clinically, both dementia with Lewy bodies and Parkinson's disease dementia share some core features which make up Lewy body dementia. Predominantly, the condition has fluctuating levels of cognition and alertness, and this can change by the minute and by the hour for people. There is rapid eye movement, REM sleep disorder, our topic for today. There are visual hallucinations. These often present as animals or people, including children. And there's Parkinsonism with slowness, stiffness and tremor. Cognitive decline and dementia can also feature with attention, executive and visual spatial function being particularly affected, though memory recall is less affected. Next slide, please. And as you can see from this feature summary by Galvin in 2019, there can also be autonomic disturbances. Okay, I'm now going to hand over to Rachel for an in-depth look into sleep disturbance.
Thank you, Angela. So I'm going to run through some of the different types of sleep disturbance in Lewy body dementia. So Daniel, can I have the next slide, please? So I'm just going to start off with a kind of very overview about what's so important about sleep. As you probably know, it's really essential in maintaining good health, our well-being. It's really involved in supporting our immune system. There's some studies showing about its function in terms of brain repair and tissue repair. But for people with dementia, it can be quite challenging. And this is for both the person with dementia, but also those who care for them. Now, in terms of some of the studies, they're showing sleep disturbance can affect approximately 40% of people with Alzheimer's disease. But for people with Lewy body dementia, you'll see this can go up to about 90%. So you can see why this is such a significant problem for this group. Next slide, please. So what constitutes a good night's sleep? Well, our sleep is regulated by 24-hour circadian rhythms, sometimes known as our internal body clock. Essentially what happens is a chemical substance, adenosine, that builds up in the brain during the day to create something called sleep pressure, and this is what can help us fall asleep at night. There are influences that externally can impact on sleep, such as sunlight, temperature. Recommended about 8 hours sleep per night. I am sure in this room there will be multiple variations of this, and also things do change at the different stages in our life depending on what's going on, but about an average is, in terms of getting a good rest, about 8 hours is recommended. Now there's also the hormone melatonin, which people may be familiar with. This gets released when it's dark, and this is what tells the body to prepare for sleep, so it impacts on the circadian rhythms. Once we're asleep, the amount of melatonin in our system gradually decreases in concentration, and then when light appears, it usually stops. So this is when we're talking about sleep hygiene, which Claire will be covering later. One of the things is about thinking about things like blackout curtains. The amount of light and sleep that we expose to really impacts on the sleep that we have. Next slide, please. So there are about 4 or 5 approximately 90-minute cycles that constitute a sleep. Each sleep cycle is about 90 minutes, and there are about 4 or 5 of these within our sleep. And so each cycle has 4 stages. Stage 1 is the bit when we're just falling off to sleep, and that's when people can be easily woken. Stage 2 is a light sleep, as you're preparing for your body's preparing for sleep. Your heart rate decreases, your body temperature drops, and your brain activities do gradually slow down. Now, when we're talking about napping, which sometimes we do talk to families about, and even for yourself, it's usually we're covering stage 1 and stage 2 before you get into stage 3, which is the deeper stage of sleep. It's more difficult to wake up. This is the most restorative part of sleep. And then stage 4 is the rapid eye movement sleep. Now, during this stage, brain activity increases, and it's when we're most likely to dream. You can dream in other stages, but this is the kind of most active part. And now for us, with people without Lewy body dementia or without REM sleep behaviour disorder, we might, if you're with a bed partner, you might see sometimes their eyelids flicker, but the rest of us is paralysed. It's something that the body's kind of learned to do. So next slide, please. There are changes with age. We probably all notice it a little bit ourselves. You might find that people are waking more frequently. People may need to empty the bladder more often. There seems to be a loss of reduction in the non-REM stage 3 sleep. Remember, that's the stage of sleep that is most restorative. So that means that sleep is less refreshing. People may be napping more during the day. Now, napping is okay in short periods, but for long periods, it will affect the sleep at night. Things like drops in body temperature. People do have changes in their circadian rhythms and their sleep pressure. So it means that they perhaps go to bed earlier and they wake up earlier. Also, there's lots of lifestyle changes as we get older. So perhaps people may be spending less time outside. Sunlight, as we know, is important. People may be less active, and of course, activity, exercise sometimes helps us sleep. Physical health problems can really impact on sleep. So if somebody's in pain, or they've got restless legs, or there's problems with continence, this will impact on their quality of their sleep. And also, as people get older, there seems to be less melatonin secretion, and I spoke earlier about the importance of melatonin. So next slide. So what happens in dementia? Well, there seems to be physical changes to the brain. So there's something called the suprachiasmatic nucleus, which is this is a bit that's nuclei that are located in the hypothalamus, which can be damaged as when there are changes in the brain as a result of dementia. Now, these help regulate sleep by responding to light. So if that's happening, then you can see why sleep might be affected. Sometimes the internal body clock is affected, so people are getting the wrong signals. Sometimes there's excessive sleep during the day. People may wake up not knowing what time it is often a problem with orientation. And also people may be familiar with the term sundowning, which is towards the end of the day when the light is decreasing, and that can make it kind of quite distressing, that period before going to sleep, which can clearly impact on the person themselves, but also on the people who are looking after them. Next slide, please. So, sleep disturbance in Lewy body dementia. So there's all sorts of types of sleep disturbance. The one that we're going to talk to probably in most detail is REM, sleep behaviour disorder, but I just wanted to highlight some of the other things that can be affected. So as well as all the things I've just referred to, people, the reduced levels of acetylcholine and dopamine in the brain can also disrupt the sleep-wake cycle. So that we think this is why people with Lewy body dementia may be particularly affected. REM sleep behaviour disorder can occur years before other symptoms. So it's one of what we call the prodromal symptoms. So sometimes people refer to them as kind of having, when you're taking history, they'll say, well, actually, they've been having this kind of thrashing around at night for kind of about 20 years. We just thought it was something that was kind of, that happened. But it can be really important to notice it because it may be something that is an indicator. And I say may, along with other symptoms. So what Lewy bodies in the brain can cause REM sleep behaviour disorder, and this is what we sometimes call as dream enactment, where arms and legs are moving or thrashing around in bed, and this is where I talked about REM sleep. Our eyelids normally flicker, and for somebody with this condition, they're actually acting out their dreams. So if they're playing football or they're chasing somebody, their arms and legs will be moving. Another common problem, and we find it a lot with some of the families we support, is people complain of excessive daytime sleepiness, and it's possibly linked with cognitive fluctuations and apathy as well, but people really have a problem with staying alert during the day. Other things that can affect sleep are the Parkinson's-related symptoms such as restless legs, sleep apnea. That affects the quality of sleep, maybe the ability to turn over in bed, the stiffness and rigidity, and also nocturia, this autonomic nervous system symptom where people got bladder sensitivity, and so they're being woken up to use the toilet. Apathy can impact on the ability for people to want to keep active during the day, and nightmares. So I think the next three are kind of linked, I think. So perhaps sometimes people not being fully alert when they wake from sleep, they may wake up slightly, a little bit mixed up. They might be actually in the middle of a dream. People often talk about night terrors, and these can be quite distressing. And they may also be responding to hallucinations. All of these clearly are going to be impacting on the person's sleep and the person who's looking after them. And then also people with Lewy body dementia will be affected by insomnia, which is a kind of common problem amongst many people. So next slide, please. So this is just a table taken from an open access article, if people are interested, by Elder et al., which talks about sleep disturbances in Lewy body dementia, and they did a systematic review. And you will see here, quite interesting, there's a bit of a comparison between DLB, dementia with Lewy bodies, as Angela referred to, and Parkinson's dementia. I'm not going to go through this in detail, but you will see the difference between the subjective, this is the reported, self-reported problems with sleep, and the objective, this is when it's been measured, and such as things like polysomnography, which we'll talk about in a minute. It seems that subjectively the REM sleep behaviour disorder is more prominent in DLB. There's possibly more studies, which might be why this is happening, but certainly nightmares about the same. The excessive daytime sleepiness, again, massive variation, but there's just, anyway, do have a look at that paper if you're interested. So next slide, please. So REM sleep behaviour disorder. As I said, this is rapid eye movement, and it's prevalent in about 80 to 90% of people with DLB, possibly less prevalent in Parkinson's dementia. How it's measured by polysomnography. So this is a sleep clinic. They're not massively readily available, but this is where people get kind of hooked up to electrodes, muscle movement, brain activity, and they can be observed in terms of the movement at sleep. Now, often this is not possible for people. So it might be that we're relying on the person themselves or the care partner to report. As I said, it can occur years before onset of other symptoms. And it might be that, you know, people will be reporting things like, you know, certainly care partners, like they're, you know, they've been hit, they've been punched. Sometimes people sustain injuries. That's quite common by kind of they kind of flailing their arm around and they hit something on the side of the bed. The person may or may not wake up and in fact will recall it. Sometimes they do and sometimes they don't. I've referred to the causes already, and they're just kind of summarised here there. So next slide, please. Danielle, I just wanted to remind people about the Diamond Lewy Assessment Toolkit. So we've referred to it in previous webinars. There are a couple of really useful questions in the assessment toolkit, and I would, you know, I would really recommend that people who are doing assessments include these, because we don't assess sleep often when we're doing cognitive assessments. So there's a question for the carer or the bed partner. You know, have you ever seen the patient appear to act out their dreams? There's also a question that can be used for the person themselves. Have they ever been told? And there's quite a lot of validity. There's a study that's been done about the validity of these questions, and they do seem to pick up REM sleep behaviour disorder quite well. So next slide. So we're going to share a video shortly. This is of a couple who I have worked with. Apologies, you'll see my face flash up because I did an interview with them on Zoom, but talking about the impact of sleep disturbance on them. So the sound might be quite quiet, but there are subtitles. So I would really recommend that you turn up your volume as far as they can on your computer. And if you're really struggling, apologies, but do just follow the subtitles. So hopefully we can start playing that, Danielle, and we're going to do it from part way along. So bear with us.
It's such a big void between the two. It's incredible. You couldn't meet a kinder, more gentle person, but Keith Sleep's a different thing altogether. But he doesn't know he's doing it. He hasn't got a clue he's doing it.
No.
You're just like acting out, aren't you? Whatever is in your head, what you've watched on telly or whatever. I mean, it's funny now when I think back. We used to watch sports. You watch quite a lot of sport, don't you? And if you're watching somebody running, and he'd literally be running along with them, sitting at the side of me. Or if he was watching tennis, he'd be going for the ball, and basketball, he'd be going for. I was just thinking, for God's sake, stop sitting there, get on there and play with them if that's what you want to do. Because now I think, oh, maybe that was Lewy body, maybe that was starting in the background, but it was quite amusing at the time.
Yeah.
It was horrendous because I was working then. I mean, I had to give up work 5.5 years ago to look after Pete, but yeah, I was a deputy manager of a supermarket, so I was working very strange hours. Sometimes I'd be leaving the house at 5 o'clock, and I might have been up 3 or 4 times in the night with him, or he might have been, if he's really performing. The problem is if somebody wakes you up with an ear-piercing scream, your adrenaline kicks in, they roll over and go straight back to sleep. And for the next hour, you're in fight mode, you know, so there's no way you're going back to sleep. So yeah, I was pretty exhausted all the time, wasn't I? I used to worry about driving to and from work because sometimes I was driving quite long distances, and I'd be quite scared that I was tired, because yeah, it was really challenging. That point was hard, and sometimes I'd go into work and say, wow, look at this bruise here, you know, he's done this, or look at this bruise on my leg or whatever. People must have thought I was a battered wife.
Yeah.
But it was just the night terrors, you know, it was genuinely what it was, wasn't it? But yeah, I could never relax. If we went on holiday, I had to look round the room and think about, you know, what might he break. He would punch bedside tables, so I had to move them so that they weren't close enough that he could actually connect with them. So you're just on your guard all the time, aren't you?
Yeah.
About what might happen. I think it's routine is the main thing, isn't it?
Yeah,
It's the fact
yeah.
that although you get up very late and you're very miffed if we have to get up early because we've got a hospital appointment or something, but getting up at a scheduled time, going to bed at a scheduled time, having those 2 hours in the day where he does have a sleep, melatonin made a big difference. That certainly helped. And he's on mirabegron as well because he was constantly getting up to go to the toilet,
Yeah.
weren't you? Um, Whereas now with the mirabegron, it is maybe once, possibly twice a night, isn't it? It'd be anything up to 8 times sometimes before that. So yeah, mirabegron made a big difference. Melatonin made a big difference.
Yeah.
So yeah, I feel at the moment we get on quite lightly for now, but who knows, what's to come. But yeah, I think those two and the routine is what's made the biggest difference,
Yeah.
isn't it?
Yeah.
Yeah.
Okay, so thank you. Thanks to Manny and Keith. Obviously gave the permission to use that. I'm going to hand over to Claire now, who's going to talk us through some sleep strategies. Over to you, Claire.
Hello, thank you for that. So I'm just going to go through some basic strategies for managing sleep issues with the Lewy body. But first of all, we're going to have a quick case study. So next slide, please. So I've just done a quick case study. I'm going to give you 5 minutes or so to kind of answer the questions on the next slide. So this case study is Mrs. A, who is a 72-year-old lady diagnosed with Lewy body dementia two years ago. She lives with her husband in a house, so she's got stairs she needs to go up and down. She is independently mobile at home, but does experience some freezing of gait. So this is usually in like small spaces. So downstairs toilet, kitchen corners, those sort of places. She can become agitated at times during the day. This is quite common and can be a particular difficulty for her husband. She also experiences some hallucinations, usually early evening time. And her sleep overnight is broken. So she has some REM sleep behaviours that Rachel was talking about, some acting out of her dreams. Which can obviously have an effect on her sleep as well as Mr. A's sleep. And then during the daytime, she just regularly nods off in front of the TV during the day. If she's not doing anything, she'll just fall asleep on the sofa, that sort of thing. So this is a regular pattern for Mr. and Mrs. A. So I'll just have a look at the next slide. These are just some questions that I want you to have a think about. As a professional, if you're supporting this family, what advice might you offer to the person with dementia? So to Mrs. A, what kind of advice would you give her? What advice might you give to Mr. A, but also any kind of family or caregivers? What any other actions you might take, and what kind of resources are you aware of? So we'll kind of flip in between the questions and the case study for the next 5 minutes. Put your answers in the chat. We'll keep an eye on those, and then we'll answer them at the end, if that's okay, after I've gone through my strategies. Okay, I'll give you 5 minutes. I'll keep an eye on the chat. Will you go back to the case study, please? Thank you, Donna. Okay, thank you. There's been lots of chat. That's been great. Thank you. That's mainly things about routine and sleep hygiene, that sort of thing, external services and that sort of thing. So I'll continue to go through the strategies that I've got here, but obviously keep a lookout in the chat because there's lots of different things in there as well. So I think it's really important just to note about fatigue, because any condition under the Parkinson's umbrella will have fatigue as a huge issue. And obviously this is mainly because of the reduced attention and concentration. So anything any of these patients are doing is going to take more effort to do, which is obviously going to mean that they're going to fatigue more. They're going from an automatic kind of processing back to a manual. Kind of everything they need to do, their full focused attention is going to be needed. Things take longer to do, more fuel required, those sort of things. So all activities are going to take more effort. So also things like a tremor. If there is a tremor, this will increase fatigue. They're moving constantly all the time. If there is any more anxiety, then this is obviously the fight or flight system. So that will increase fatigue, the kind of increased heart rate, that sort of thing. Then, as we've talked about, Parkinsonism disrupts the natural sleep pattern. So there'll be broken sleep or not quite as effective sleep. The slow wave sleep is not as apparent. So they're not going to get the benefit of sleep. And then obviously if there is increased agitation or hallucinations, they can increase anxiety, they can have an impact on their sleep routine, and this can all exacerbate low mood. So generally, just down to the condition, it's, fatigue is going to be a really huge issue. And we know that if somebody's more fatigued, they're less likely to sleep well at night as well. They're more likely to get stuck in the REM sleep stage of sleep. So if we can manage sleep in the daytime, or manage fatigue in the daytime, I should say, then we should be able to reduce the REM sleep to some extent as well. And I think somebody said in the chat also about just really going through this, advising this information, giving this information to patients and carers is really important to make them realise it's part and parcel of the condition. Okay, so the next slide, please. So we know definitely that routine management or managing routine is really important thing to help with managing their sleep. So how do we do this? What do we need to do? We need to look at breaking the days into different activities, different periods of time. I use a timetable regularly, so by encouraging patients to get up at the same time every day, go to bed at the same time every day, and have a daytime rest. But as you've said in the chat, we're looking at different activities. It's really important to vary activities. So you may have things that happen the same time every day. So we eat our meals at the same time every day. We have medications at the same time every day. But all other activities need to be varied. It's really important, and include both physical activities and mental, cognitive activities. Encourage the patient to think about all the different things that they can use an activity. This might be getting out photographs, going through different photographs, just some cognitive stimulation, which might just include picking a topic of conversation that they might have for, say, half an hour. Might be sport, might be reminiscence, it might be holidays they've gone on, all of those sort of things. So there's lots of different activities that we can think of to use during the day. Obviously, the patient needs to enjoy these activities. And it's also worth looking on the Parkinson's UK website, the Lewy Body Dementia Society website, but also kind of Googling any kind of activities for Parkinson's, because anybody with Lewy body dementia will be welcome on, if they're able to kind of go to all the different activities, groups, those sort of things. So it's looking at what's available for them. As I said, we need to vary those activities. It's really important. So yeah, advise a structured sleep in the daytime if possible. So as Mrs. A was just generally nodding off at points during the day, it's really important to have a structured sleep. The thing about having 8 hours sleep overnight is really important, but it's about having a sleep pattern over a 24-hour period, thinking of it in that way. So part of those 8 hours might be in the daytime. If somebody's having less sleep at night, let's encourage them to have more sleep in the day. But even if somebody is sleeping well from, say, 10 o'clock at night till 7 o'clock in the morning, it's a long time for them to be awake from 7 in the morning till 10 o'clock at night. So to have a time in the day where they actually go and have a lie on the bed, 30 to 45 minutes is the optimal time, but if somebody's really struggling with their sleep, they may need more than that. And as you saw in the video, that chap was having a good couple of hours, which obviously did him good. So it really depends on individuals. But yes, it's definitely about having the structure. If somebody falls asleep in front of the TV, they just drift into kind of high level sleep. And then go maybe straight into active sleep, and they're not getting enough restful slow wave sleep, so they're not getting the benefit from it. So the structure of the daytime sleep is really important. They may need a couple of these a day if required. As I said, get a timetable for them, put a timetable up so they visually can, refer to the timetable regularly. And if activities are planned, then they're more likely to do it. The motivation will be there if activities are planned. If they're not, to internally motivate patients to do things, it's really tricky. Music is a really good media for managing sleep and agitation. So we use music all the time for managing Parkinson's conditions. So we use music to initiate movement, but it's also really good for kind of relaxation, relaxed times where a patient is agitated by using some music they enjoy that's quiet and relaxed. It might encourage them to, just slow and take an hour out or something to just kind of relax and calm themselves. It can also be used at night to encourage to sleep. If somebody's struggling to get off to sleep, something on at night they have sleep buttons on some radios and things. It might be useful just to put something on just to encourage them to go to sleep. It is really important that the medication regime is correct and regularly reviewed, because the levels of dopamine overnight are important. We don't want somebody to be moving a lot overnight. We also don't want somebody to be unable to move overnight. So something like silk sheets or something as well might be useful. But the actual medication regime has got to be right. And then obviously use some sleep hygiene techniques. So next slide. We'll just go through a few of these. So this is just about encouraging sleep. So obviously avoiding stimulants in the evening, so not having caffeine or anything too late at night before they go to bed. They might need to reduce their fluids for a couple of hours before they go to sleep. The regular pattern of sleep is really important. So encourage patients to go up at the same time every night in the morning, go to bed at the same time every night. It's better. This is good advice for anybody, because if you have a lie-in or if you go to bed early, it kind of disrupts your circadian rhythm. So it's always good to get up at the same time every day and have a daytime sleep. Make sure the bedding is comfortable, the bed's comfortable, and the temperature is right. Not too hot, not too cold. Probably better to be slightly cooler than warmer, but really again depends on the patient. As said, we need to look at maybe using aids to assist movement and comfort overnight. So if silk sheets are needed, or a bed stick, bed lever. Obviously these can be tricky to get hold of in some areas, but it's certainly worth having a think about. Restriction of daytime siesta. This is about this structured sleep. This is really important. Advice regarding to exercise to induce sleep. So again, more activities in the daytime, so physical activities. We know that getting outside every day will help sleep. Okay, so if the exercises can be outside, that's great. But any kind of seated exercises or anything at all. So physical activity will help manage fatigue. If somebody's less fatigued, they're less likely to have hallucinations, less likely to have REM sleep behaviour. And exposure to natural light. We know that getting outdoors, getting sunlight daily can induce sleep, and that's really important. So these are really kind of just general sleep management techniques that we can use for anybody. Okay, the next slide, please. So just thinking about some other treatments and medications. So there is limited efficacy of medication to help sleep, but reviewing the medication that might be disrupting the sleep is really important. So any antidepressants or beta blockers or anything like that, or have a review. When I talk about review medication, it's not just about encouraging the sleep ones, it's about looking at it as a whole. There are sedatives excuse me, that can be used. So temazepam, this can sometimes cause harm and increase the risk of falls, but things like zopiclone, zolpidem might be used for insomnia. I have lots of patients on zopiclone or clonazepam, not necessarily taking them every night, sometimes taking them every other night or taking half a tablet every other. So it varies with patients, but it can work just to initially get them into a good sleep pattern, not necessarily long term. Cholinesterase inhibitors like donepezil or rivastigmine and glutamate receptor antagonists like memantine might be used. Might increase wakefulness, but some studies show it has improved sleep quality. This might be if they're given earlier in the day. And just thinking about that, there's one patient that I heard that actually had a main meal in the daytime rather than the evening, and that improved their sleep disorders as well. So that might be worth thinking about. And then in Lewy body dementia, some evidence for REM sleep behaviour disorder using melatonin and clonazepam. CBT might be used for insomnia. So, something about, are they struggling to get off to sleep due to anxiety or low mood or anything like that? Could this help? And Dream Start is a recently been researched. It's about developing individual strategies. Do you want to go on to the next slide? And I'll just talk about that in a bit more detail. So it's about getting individual strategies for patients. So it's an individually tailored plan for patients. The research around it has finished, but it's not yet been published. So this will be hopefully available for people in the future. But again, it's just a way of getting the plans available for individual patients, looking at light and bed routine, that sort of thing. So look out for that in the future. Okay, next. So always use the resources as well. Be aware of what are resources around the Lewy Body Society, and I use these all the time. I've got some really good information booklets around managing sleep disturbances, helps sleep habits. They've also got some for hallucinations and those sort of things. It's really useful to use these information booklets. And the dementia toolkit, as we've said, about a good night's sleep and the fact that sleep is important for everyone, is all, the resources are there for you. So use those. And I think in the chat it says it's really important to get information about what's available for these patients, so respite and that sort of thing, so that to help with caring for those patients too. Okay, I think that's me done.
Thank you, Claire. That's great. So we've got a member of the community practice who wanted to share some of her work around sleep posture. So there you go, Louise. Hopefully you're there, and we can invite you to speak. Brilliant. There you go.
Hi.
Talk us through this, yeah.
Yeah, thank you so much. So really helpful. So basically what I've been doing is looking at sleep posture. So what position does someone sleep in and what impact does that have? And so one of the things that seems to have dropped out of our language is, are you comfortable? Are you lying comfortably? And when we're doing sleep information, sorry, just one second. Can you just leave that a second? Sorry, my colleague is packing boxes on the other side of the room and it's making a very loud noise. Yeah, so the what we're looking at is with sleep posture is saying, are you comfortable in bed and what strategies can we use to help with that? And where you've got somebody with Lewy body dementia or with Parkinson's disease, it's known that they have difficulty moving in bed. And so what we're trying to do here is define what comfort is. So comfort is about, it's easy to move, your muscles are relaxed and you're not in any pain. So one of the things that we recommend is we're looking at is just do these 3 simple checks as a starting point to sort of say, when you're in bed, are you achieving this? So I've just been working with a palliative care consultant studying non-pharmacological interventions for sleep, and he was saying, I've not even asked this question, but it's really, really important to sort of explore it. And then what are the contributing factors? So one of the things is asking about sleep surface. So people who are on airflow mattresses find it difficult to move, and actually they might not need that airflow mattress if they don't have pressure concerns. So it might be worth looking at that. Memory foam can be challenging to move on. The practice or cues, make sure they're familiar with the cues that I can use to get a good move in bed. Optimized position. So Claire just mentioned there about bed levers and satin sheets, but there's also wedges and other rolls that may be able to get someone in a better position so that it makes them easier to sleep. Looking at those position aids, so looking at the base of support. So if you've got people who've perhaps got changes to their range of movement, make sure they are supported in bed. And then something we call provocative postures. So the evidence is coming out now that certain positions where we sleep with rotation in the spine are more likely to make us wake up with back or neck pain. But also we're finding in the work we're doing is actually they disturb sleep. So when you slightly rouse, if you are uncomfortable, you're more likely to wake up fully, and that in itself can create a sleep disturbance. So we're at the start of a research journey with this, but we have got a manifesto I'd love to share with people who are interested, which is all about the right sleep surface, but also about incorporating comfort and positioning in bed as part of our normal pathways. Thank you.
Thank you, Louise. That sounds fascinating. So I think when we've got our website up and running, that might be something that you're happy to share in the login area. So I can see a thumb going up. So thank you ever so much. I'm going to hand you back to Angela, who's going to just look at some of the questions. Thank you for all your contributions. Over to you, Angela.
Thank you. Thank you to all our speakers today. We've just got 9 minutes left. We've got a couple of questions from the first talk, Rachel. When you were talking about REM sleep disorder that it may be an indicator for Lewy body dementia, sort of 20 years even beforehand. Matthew asked, would a clinician act on this sort of with respect to LBD? So like for monitoring of development or progression?
Yeah, good question, Matthew. So I think if you've picked it up, it is really clearly one of the prodromal features, but it might not be Lewy body dementia because, of course, people can have REM sleep behaviour disorder for other conditions as well. But I think in terms of, let's say somebody had MCI, mild cognitive impairment, and the other prodromal feature for dementia with Lewy bodies particularly are repeated deliriums. So collectively, just gathering that information, you know, making people aware that it may be significant, asking the questions in memory services, alerting GPs to monitor it. I think when people cumulatively develop other symptoms as well, that may be an indicator. So I think good idea to monitor. Thanks what I'd say, Angela.
Lovely, thank you. Just before I go on to the next one, I'll just say we'll put a link to a survey in the chat now, just in case a couple of people might be heading off early, because we like to just get your views on the hour at the end, just to help us develop the webinars further. So that link will go in the chat. It's in there now. Okay, so next question. Just talking about from the video, really, we saw the patient's wife doing a lot of the talking, you know, within that video. And Matthew asked, you know, is it normal for the main care provider to do most of the communication and to be given the information, and how can we be sure of the accuracy of it? So there's a couple of points there, I suppose, to do with a person with Lewy body's communication. Obviously, it depends on the person. You know, some people will be able to tell you themselves. Some people will have communication difficulties, and we are going to be doing a webinar on communication in Lewy body dementia as well later on in the year. So it depends on the person, doesn't it? In terms of accuracy, Louise, and was it Louise who's just spoken, did put a really good idea in about objective measurements, indicators, sleep maps, and use of technology, which is something to think about for objectively measuring sleep. And then Jane, who's also an Admiral nurse, was talking about using talking mats, which is a communication kind of augmentative and alternative communication method. So if you've not heard of that, there's a link in the chat about it. And also talk to your speech therapist in your team and make some referrals if that's going to be useful. I don't think there's any other questions in the Q&A. And if I've missed one in the chat, please do pop it in again. I think that's us for now. Oh, can we have the PowerPoint emailed, please? It will be, it will be on the Community of Practice website. So this is coming into our last slide now. Please do register for the Lewy Body website, and the link will be going into the chat now. You can join the Community of Practice from there. There will be resources on the website in due course, including the recording from today and the PowerPoint presentations. Our next meeting is in October, if you'd like to get that in your diaries now, and that's for communication in Lewy body dementia. And that brings us to the end there. Thank you ever so much for coming and for being part of the Community of Practice. Hope to see you next time. And thank you very much for our speakers today.